everyone. Thank you for joining us for our awards, lectures, and convocation. I'm Maria Prom, chair of the Research Subcommittee, and it is my honor and privilege to introduce you all to this year's Katon Research Award Lecture. The Wayne Katon Research Award honors an individual currently studying psychopathology in the medically ill and is intended to recognize a currently active researcher in the field. This year's recipient is Lydia Trosiak. Dr. Trosiak is a psychiatrist, internist, and health services researcher who is professor in the Department of Psychiatry and Behavioral Sciences and adjunct professor in the Department of Global Health at the University of Washington. Her research over the past 21 years has aimed to improve care and outcomes for people with complex needs in low-resource settings, such as low-barrier primary care clinics and community mental health centers in the US, and primary and secondary medical settings in India, Nepal, and Cambodia. Please welcome Dr. Lydia Trosiak.
Thank you, Maria, for that very kind introduction. And I just want to thank the Academy and the committee for the invitation to speak tonight. I'm so honored to receive this award, and particularly so because it's dedicated to Wayne Katon. Wayne was a wonderful mentor to me throughout my early and mid-career, and as you all know, a pioneer in integrated care. And my talk this evening is about integrated care. I'd like to share some of my experiences about using integrated care as a strategy to manage clinical complexity, and how integrated care models can improve both mental health and medical outcomes. And I want to share some strategies that we've learned about efficiently scaling models in low-resource settings. I have no conflicts to disclose. So our starting point is that it is widely accepted that integrating care, literally bringing mental health services to where people are receiving other medical care, is a powerful strategy to increase access to mental health services and to address the mental health treatment gap. The gap has been recognized as a major public health challenge for more than 40 years, right? This isn't news. So the recent data that 1 in 4 adults in the US meet past year criteria for mental disorder, but only 60% receive treatment, and that global numbers are even more concerning. Almost 1 billion people in the world live with a mental disorder, but about 25% receive any care at all. But there are also mental health treatment implementation gaps, and these are what I want to focus on this evening. First, there's the mental health treatment gap is not evenly distributed across populations. There are substantial disparities with respect to access to care across geographic regions, demographic groups, and in particular among people living in poverty. Second, that even among people who receive care, the vast majority are not receiving evidence-based treatment. They're not receiving effective care. And in many places, evidence-based treatments are not delivered with fidelity, so patients aren't receiving adequate treatment, and they're not treated to remission. And a final gap that I want to highlight, is particularly relevant tonight, is that most integrated care models miss opportunities to provide a more holistic approach to people who have multiple chronic conditions, and to better integrate treatment for multiple disorders. Multimorbidity is the new normal. I think most of us who work in outpatient psychiatry, outpatient CL psychiatry, understand this, that 42% of US adults have more than one chronic condition, and among people with chronic conditions, 75% of them have a behavioral health disorder. So these very high rates of multimorbidity provide a strong rationale to integrate behavioral health services into physical disease programs. And these are HIV or NCD, diabetes, cardiovascular disease programs that are either within primary care settings or are in the specialty care settings themselves. In addition, physical disease programs have an infrastructure for the care of these chronic conditions that can be leveraged to more efficiently integrate care. They've got staff and workflows, tools to track and report data. So for more than 15 years, policymakers have recommended integrating mental health care, right? This is the work that a lot of us do. But what's really exciting over the last 2 years is that there have been several calls to action by very high-level policymakers. The World Health Organization's Mental Health Action Plan for 2019 identifies 5 priority non-communicable diseases, and one of these is mental disorders. These are priorities for ministries of health around the world. And then secondly, the UN Political Declaration on HIV and AIDS for 2021 to 2026 actually specifies targets, right? It goes beyond the recommendation that we should integrate care. It specifies that 90% of people living with HIV should be linked to person-centered, context-specific care for HIV, NCDs, and mental health. So, a real call to action for us. So I want to share some of our team's experiences that provide evidence that one integrated care model in particular, collaborative care, can be particularly effective for co-treating multiple chronic conditions and can improve both mental health and medical outcomes. And I'll focus on how we've been working to apply lessons learned in research trials to our ongoing efforts to scale this model across diverse low-resource settings. And just as a background, it's important to acknowledge that there are a lot of effective integrated care models. Meta-analyses have identified more than 50 different models that can improve outcomes. But the model that we've implemented is the collaborative care model that is the original model from the IMPACT trial that Jürgen Unitzer published 20 years ago. And it's a multi-component model that's based on the chronic care model. And I think it's familiar to a lot of you in the room, but I want to highlight in the ways that it's the unique characteristics of the model that make it particularly well designed to treat multiple conditions. First, it's a team-based approach to care. And of particular importance is there are roles and responsibilities for medical providers, for the primary care physician as part of the team. There's a dedicated care manager who's responsible for team communication, support of functioning, monitoring performance of the team, and they often typically deliver the evidence-based psychological interventions. And it's a data-driven model. It's a stepped care approach where treatment for individuals is monitored with validated clinical scales, and treatment is intensified until the person responds. And this measurement-based care is an important component, but what's unique, I think, about the collaborative care model is that there's also treatment to target, that there is treatment, disease-specific targets, and treatment is intensified until these targets are achieved. And then finally, it's the population approach, I think, is very different about collaborative care. In addition to the data-driven approaches to individual care, the teams have responsibilities for monitoring program performance and using QI strategies to improve program performance. So with that brief background, I'll start by describing several of our experiences in lower middle income countries, including a multi-site clinical trial in India to treat depression and diabetes, and a current collaboration with the World Health Organization on efforts to implement a collaborative care model at scale. So our independent trial was a clinical trial of a 12-month collaborative care intervention to treat poorly controlled diabetes and depression. It involved 404 adults in 4 diabetes clinics in India that were located throughout the country. You can sort of see them on the map, and they were very different sites from each other. And this project was just a wonderful collaboration with colleagues from the Global Diabetes Research Center at Emory University and the Madras Diabetes Research Foundation in Chennai in southern India. And I want to focus on what we learned during the trial that has informed our thinking about how we can implement models like this at scale without the support of funded clinical trial. But I'll first share the effectiveness findings, because this was the first integrated care intervention to improve both mental health and medical outcomes in a lower middle income country. So the first aim of this study involved adaptations of the intervention we were using in the US for both the Indian culture and the context of diabetes specialty care clinics. And this was a year-long, very intensive qualitative research study that included more than 80 participants at 3 of the 4 study sites. So we interviewed and did focus groups of people who were living with diabetes, who also had depression, their family members, staff, providers in the clinic. And the take-home was that participants were really enthusiastic about the idea. They liked the increased availability of mental health treatment, increased access to it, but beyond that, they liked the philosophical approach that treating depression was part of their diabetes care. So, but there were three major themes that emerged around things that we had to change about the model we were using in the US. And I want to share them because as I talk about the process evaluation, we really looked at whether and how the teams, the collaborative care teams at the sites made these adaptations during the trial. So the first was the recognition that family members are a really important part of diabetes treatment in India, and the teams had to really think about how to engage families in the intervention, in the treatment. The second was recognition of the average level of literacy or health literacy of people coming to the diabetes clinics, and that we really needed clear and simple information for patient education materials. And then finally, just that there's a substantial amount of stigma in India associated with both depression and with diabetes. And so the teams really had to be strategic about how they addressed stigma within the intervention. So the trial itself was really straightforward, right? People with diabetes came to their diabetes clinic for care, and if they were recognized as having poorly controlled diabetes on the basis of any of these cardiometabolic indicators, they were screened for depression. If they met the inclusion criteria, they were consented and randomized to either enhanced usual care, which meant their provider was informed that they had a current major depressive episode and offered kind of resources and referrals, or to the 12-month collaborative care intervention. And this was similar to the model I just described, right? We had a team approach. In this case, the team involved adding a care coordinator who was an allied health professional, so kind of like a certified diabetes educator to the team, and a team psychiatrist. And outcomes and process measures related to both depression and diabetes and cardiometabolic indicators were tracked over time in a registry, and then the team, which also included a consulting diabetologist or endocrinologist, met every 2 weeks to review the caseload. What wasn't typical about the trial was that the primary outcome was not depression. This was not a depression treatment trial. It was the outcome was a composite measure of the percent of patients who improved had clinical significant improvement in both depression and cardiometabolic indicators, and that our primary endpoint was 24 months. So not the end of the 12-month intervention, but at the end of 24 months. And we did this because there were so many studies that had showed that the effectiveness of collaborative care, that we were confident people would have improvement at the end of 12 months, but we wanted to see if there was any sustained improvement. So, sort of cut to the chase about effectiveness, the collaborative care group was superior with respect to the primary composite outcome at 24 months. And the figure on the slide is from the primary paper, where we see the collaborative care group in orange on the top, and this is sort of tracking the primary composite outcome measure over time. And you can see that the groups moved apart. By the time we had collected our first data at 6 months, the groups had already moved apart. The difference was greatest at 12 months at the end of the intervention, and though even the difference between the groups narrowed slightly, it was still statistically significant at 24 months. And so we examined also the individual outcomes and really saw that the overall effect was driven by a rather robust depression treatment effect, but A1C was different across the groups over time. So I want to turn now to summarize the findings of the process evaluation of this study, because we conducted this evaluation to understand who the intervention worked for, under what circumstances, and to gain some information about how it worked. And the process evaluation was a mixed methods approach that was embedded in the trial. It involved a comparative case study at 2 of the sites. And it was informed by the realist evaluation framework, which is a theory-based model that emphasizes the importance of context for program outcomes. And we did the comparative case study at 2 sites for pragmatic reasons. It was a very expensive and resource-intensive approach. And we picked the 2 largest, very different sites, the big public health hospital in Delhi in the north of India, and then our private Diabetes Research Foundation, our coordinating site in the south in Chennai. And this work was led by Leslie Johnson from Emory, who did her PhD thesis in implementation science. This process evaluation was her thesis, and she's now a faculty member there. But we kind of developed, following the framework, we developed a theory and a logic model, and then Leslie and her team collected all sorts of data to test our theory and our model so we could revise it. And so we learned about both the changes that the teams, the tailoring that the teams were doing to the intervention itself as the trial was going on. And we also learned about the critical issues that we need to be thinking about in the early implementation period as we plan to scale this intervention. So, very reassuringly, we saw that there were efforts to really address stigma, literacy, family and natural supports, and the creative ways that the teams actually did this in addition to how we had adapted the study materials. I think that the implementation issues are interesting, though, too, and I think the themes that rose to the top related to workforce issues, in particular the critical importance of supervision, the need to support the teams, specifically support team functioning, and then thinking about what evidence-based interventions are a good fit. And the two things I'll highlight is just how much implementation support we provided within the context of the trial. And still, the psychiatrists on the teams were providing a lot of education, supervision, support, teaching. And so we're really thinking about, without the support of a trial, will this be the role of the psychiatrist on the team? What are the other potential sources of supervision? And we also saw the care managers, the care coordinators had this wonderful sense of peer support and community, and we had monthly support calls for them as part of the trial, but they really sort of pulled together and offered each other a lot of support. So building on the work in the independent trial, we have a current collaboration with the World Health Organization that relates to implementing collaborative care at scale. In 2019, the head of the mental health unit approached the AIMS Center at the University of Washington to partner on developing a manual to support the implementation of collaborative care in low and middle income countries. And the idea was that there was a need to integrate care. They wanted the most robust model with the largest evidence base. And so over 2 years, we worked on developing a manual based on 20 years of the AIMS Center experience in implementation across diverse settings, our experience in the independent trial that I just described, and then talking with colleagues, consulting with them who are doing similar work in South Africa, Nepal, and China. And the goal is to develop a package of implementation materials that any country could use to develop, implement, and sustain a collaborative care model that's tailored to their own context. So we've got a 3-year pilot study to field test and evaluate the model and materials that we're developing. And we're kind of finished the first phase of the field testing. It's been a really fascinating study. We've identified partners who are 9 TB and HIV clinics in Ghana, and then 20 NCD clinics in the Dominican Republic. They've done their situation analyses, so we're working with them to understand what their model might look like, what's their workforce, what are their resources, what's their QI capacity and data tracking capacities. And so we're finalizing the manual, the training materials, the training plan, and the plan is to train the teams in early 2025. They'll launch the programs, and our goal is to have all of this implementation package kind of freely available on the WHO website by 2026, so we'll see. So I want to end with sharing a little bit about our experiences in adapting what we learned in these projects in low and middle income countries to implementing collaborative care a lot closer to home. And this is work that we're currently doing in King County in a low barrier HIV clinic that serves people who face challenges in accessing traditional clinical care settings. In 2015, we're very proud that King County was the first U.S. Geographic jurisdiction to achieve the UNAIDS 90-90-90 target. So that meant that 90% of people who have HIV have been diagnosed, 90% of those who are diagnosed have been linked to treatment, and 90% of those on treatment are virally suppressed. But what we've seen over the last 10 years is that there are troubling disparities in the HIV epidemic in King County, and this is very representative of the epidemic in the US currently, that when we look at that last kind of 10% or 5% of people who are not achieving these targets, these are typically individuals who have substantial psychosocial complexity and face individual and systemic barriers to engaging in traditional healthcare settings. So in 2015, the HIV clinic at our county hospital in Seattle and the Seattle King County Public Health Department created something called the MAX clinic, the Maximum Assistance Clinic, to address the needs of people with HIV who are not well engaged in HIV care in the county. So MAX is a high-intensity, low-barrier, incentivized care model for people with HIV. It offers walk-in primary care and HIV care, intensive case management with wraparound social services, and incentives, cash and food and bus passes for laboratory tests, pharmacy pickups, achieving viral suppression, a lot of cross-agency coordination with the King County Jail, public health surveillance data, a lot of community partners, and it's really just been a fantastically successful model. It's helped people really engage in care, achieve viral suppression. It's now recognized by the CDC as a best practice for HIV care, and it's been implemented in other cities. We now have 4 other low-barrier primary care clinics in King County. So I became involved in MAX in 2018 to help the team work on addressing the substantial unmet behavioral health care needs that they identified in their MAX, in the patients coming to MAX. The team and the care model were already complex. There's a lot, there's 9 people on the team, and there's a lot of services being offered and a lot of things to track, but there was no specific strategy that identified and addressed and treated behavioral health comorbidities. And so when we looked at the clinic data to try to understand what was happening, we saw that among the 227 patients who were enrolled in MAX, almost 70% of them had a mental disorder diagnosis documented in their chart. And 71% of those patients had a documented referral. And we have a big county hospital campus, so most of the referrals were going to the large HIV clinic that's across the street that has really robust behavioral health services, or to a community mental health clinic 2 blocks away. So really not a lot of geographic or administrative challenges, and yet only 33% of people had even 1 visit after a referral, and very few had more than 1. So we had a really strong justification to try to integrate, despite the walk-in nature of the clinic, to try to integrate behavioral health services. And so our first attempt to integrate model into MAX was through an R34 research pilot. And we had responded to an RFP that was seeking to improve care in depression and opioid use disorder. So we created a collaborative care model, not unlike the other collaborative care model, the one from Independent. We added members to the team. We added a half-time nurse care manager, and I was the psychiatrist. We had a registry, and we implemented routine screening with a PHQ-9, trained the nurse in a 4-session behavioral activation intervention, and we met weekly to kind of review progress and both individual progress and the progress of the program. And we learned a lot during this pilot. The approach, I think the bottom line was that, or the bottom lines were that the approach really didn't have the reach that we needed. The figure sort of shows kind of the treatment cascade, and after 6 months, we'd only screened about 1/3 of the patients who came into the clinic, and only about 15% of the patients ever met with the nurse. And there was a lot of resistance to routine population-based screening. We saw very high rates of positive screens, which suggested to us that people were doing targeted screening, not population-based screening. And there was also really low uptake of the session-based treatment, the behavioral activation by patients. So, we just concluded that there was a poor fit of trying to do a manualized session-based intervention in this walk-in setting. And this has been, in talking to colleagues who are doing similar work around the country, we're hearing the same story. So since that pilot ended about a year ago, we've revised our collaborative care model based on feedback that was built into the R34, additional kind of qualitative and quantitative data over the last 6 months or so. And the feedback was really about the fit for the clinic and the role clarity. The team, the feedback from the R34 was that the team felt very constrained by the clinical trial, that they felt like we weren't, in focusing on depression, we weren't reaching the patients with the greatest need. We just weren't addressing the top priorities of what the team saw. And then we had 3 Ryan White social workers on the team. So, why was a nurse providing the behavioral intervention? So over the last 6 months, we've been revising the model. We have added, with EHE funding, we have added a full-time licensed mental health counselor therapist who's available on a walk-in basis. And she's not doing session-based therapy. We've implemented and are testing a single session approach to counseling. And it's primarily, we're thinking of this as primarily an engagement intervention and a bridge to mental health treatment. And we've also revised the nurse care manager role, and she's focusing on the prescribing of antipsychotic medications by our HIV physicians. When we looked at the data and we saw that almost a third of our patients had a diagnosis of psychosis. A lot of it was methamphetamine-induced psychosis from emergency room visits, but there's sort of these medications, and our physicians are the only providers that some of these patients are seeing, so they were continuing medications. So I've been working with the nurse over the last 6 months to develop a registry and workflows and protocols around improving the quality of care for prescribing by our HIV physicians until we can link people to care in the specialty setting. So we're collecting data, preliminary data on this revised model, and planning to submit a full-scale trial, a grant for a full-scale trial. So I'll stop here and I hope that I've been able to show through these several examples that it is possible to adapt and implement collaborative care in low-resource settings, and that these models can improve both mental health and medical outcomes. And our experiences really highlight the need to tailor the care model and its components for the context and the target population. And when we think about the key implementation factors, what keeps coming up time and again across very different contexts is that our factors related to service delivery, workforce, and outcomes. And I think with respect to service delivery, really seeing a need for models to address a range of behavioral health disorders, it's really not helpful for our colleagues to treat one disorder at a time, one behavioral health disorder at a time, and then really thinking about which evidence-based interventions we want to include in our models, who's going to deliver them, and in thinking about workforce, who will deliver the interventions, but who will supervise these different cadre of staff. And then finally, I think, given the importance of data and outcomes for these models, we really want outcome measures that are meaningful to a broad range of stakeholders. And so as we've moved from clinical trials to implementation, I think it's been really helpful for us to remember that implementation is a process, and it's kind of like this photograph, a long and winding road. And I think all of these experiences have sort of made clear to me that even the most effective interventions are really not going to have any impact if providers don't implement them and people who need them don't receive them. So, really keeping those things in mind as we journey onward with implementation. So I'll stop here, just acknowledging my wonderful colleagues at the University of Washington and elsewhere on these several projects, and happy to hear from anyone if people have questions or feedback. And just thank you so much for attending tonight and for your attention.